Hello, everyone. Today I'm going to present a new topic in cardiovascular system. And this topic is known as the heart failure, which is known as the congestive heart failure. So far in cardiovascular system, we have covered the different topics, like we have seen about the hypertension, we have seen about coronary artery disorders, which includes angina, myocardial infarction, and so on. And also we have covered about the cardiac arrhythmias. So our next topic in cardiovascular system is heart failure. Okay. So I can say that this is one of the most important topics because a lot of patients who have this cardiac problems, they get admitted in the hospitals with heart failure. Okay, so with congestive heart failure. So let's have a look what is meant by this congestive heart failure and what is the main pathophysiology of this congestive heart failure and how we can manage this congestive heart failure. So once the patients they get presented. Okay, so at first I will begin my slide. I will present my slide. So our topic for today is heart failure. And in heart failure, so these are the topics that we are going to cover today. Okay. So first of all, we are going to have a look through what is the pathophysiology of heart failure. Okay. So what happens in case of the heart failure, and then we will see the difference between the right-sided and the left-sided heart failure. So what is the major difference between the right and the left-sided heart failure? And also we will have a look through the risk factors. So what are the main risk factors that leads to cause this heart failure? So here, when it comes to the risk factors, especially we emphasize on the medications, like are there any medications that leads to cause this heart failure? Are there any medications that are contraindicated in heart failure conditions? Okay. And then we will see about the pharmacology. That is what medications that can be used to treat this heart failure. So that is nothing but complete classification of the drugs as well as their mechanism of actions, everything that we'll cover in the pharmacology of heart failure medications. Then we'll go through the applied pharmacotherapy. Okay, so applied pharmacotherapy is nothing but here we will select an appropriate drug, okay, based on the case scenarios which are provided. Okay, so at the end, I'm going to present the case scenarios as well. So in that case scenarios, we will select the appropriate medication to the patient based on the current patient's condition. And after selecting the drug, there are also other factors that may lead that we need to that we must follow it up. That is nothing but the monitoring parameters. So what monitoring is to be done to the patients once after we select the drug therapy. Okay, so now let's begin with the first part, that is the pathophysiology of the heart failure. Okay. So heart failure, it is a complex syndrome which impairs the ability of the cardiac ventricles to pump adequate quantity of the blood to the systemic circulation. Okay, so or the adequate quantity of the blood to the body tissues. So what happens in case of heart failure is the heart, it can't pump a sufficient amount, that is the required amount of the blood to the body organs. Okay, and this heart failure, it can also be termed as a congestive heart failure. Okay, so congestive means if there is any fluid accumulated in the body, then we'll tell it as a congestive condition, congestion. Okay, so this congestion, it leads to cause like the fluid gets accumulated either in the peripheral regions of the body, okay, so which may lead to cause the peripheral edema, like especially in case of heart failure, we can notice the ankle edema, okay, or the fluid, it gets accumulated in the lungs, okay, and where it leads to cause the pulmonary edema, okay, where the patient, they have a shortness of breath and so on. Okay, so there are certain factors that may cause this heart failure, so which include the coronary artery disease. In case if the patient, they already have CAD problems, then there will be at a high risk of heart failure. Okay, and hypertension. Okay, if the uncontrolled hypertension, then it is also a risk factor for heart failure. Valvular heart disease, anemia, hyperthyroidism, cardiomyopathies, congenital heart disease, and use of certain medications. Okay, so the use of certain medications, which is the most important one. So as a pharmacist, okay, so our major role when we are working as a clinical pharmacist in the hospital, so our major role is we need to screen all the patient's medication, that is the home medications. So we need to reconcile the medications. Okay, so in case when we are doing such screening or when we are doing the reconciliation, if we find any of the medication that may leads to or that may trigger the heart failure conditions, then immediately we need to identify the drug and let the doctors know about it. Okay, so that the doctors, they will de-prescribe that medication. Okay, so de-prescribe in the sense they will remove that medication and replace it with some other medications. Okay, so here are some examples of medication that may precipitate the heart failure condition. So the first class of the drugs are calcium channel blockers. So in calcium channel blockers, there are two different types. One is the dihydropyridine, and the second one is the non-dihydropyridine calcium channel blockers. So dihydropyridine examples are the amlodipine, nifedipine, nicardipine. They all are the examples for dihydropyridine calcium channel blockers. So they got the name because they contain a dihydropyridine ring in its structure. And then the non-dihydropyridines are verapamil and diltiazem. So dihydropyridine calcium channel blockers, they mainly show the action on the blood vessels. Okay? It means that they relax the blood vessels. Whereas verapamil and diltiazem, which are non-dihydropyridine, they mainly show the action on the cardiac myocytes. They show the action on the heart. And the main function is they have a negative inotropic property. Okay? So negative inotropic means, inotropic in the sense, force of contraction. So verapamil and diltiazem, they reduce the force of contraction. Okay? So that's why we are telling it as a negative inotropic property. Okay? So positive inotropic means increase in the force of contraction. A negative inotropic means decrease in the force of contraction. So here verapamil and diltiazem, they are reducing the force of contraction. So that's why these drugs, they have a negative inotropic property. So these drugs may exaggerate or they may further precipitate the heart failure condition. Then the second class of the drugs that may precipitate the heart failure are corticosteroids and NSAIDs. So corticosteroids and NSAIDs, they have a common property, like they cause the sodium and water retention in the body. Okay, and we know that in case of heart failure, if the fluid gets accumulated, like more water gets reabsorbed at the nephrons, then the preload on the heart will get increased. Okay, as a result, the heart can't pump the blood properly. Okay, so this is another like risk factors. Okay, so that may precipitate the heart failure. So patients who are on steroids and NSAIDs, they are also at a risk of increased heart failure. Then the next class of the drugs is the thiazolidinediones, rosiglitazone and pioglitazone. So these two drugs are the examples for thiazolidinediones. So rosiglitazone, like both the drugs, thiazolidinediones, both rosiglitazone and pioglitazone, they are considered as the oral hypoglycemic agents. They are used in the management of type 2 diabetes. Okay. So rosiglitazone is completely removed from the market because rosiglitazone has got a high risk of fluid retention in the body. So it causes a high fluid retention in the body. Okay. So as a result, the patient, they develop the uncontrolled hypertension, as well as the patient, they will have this heart failure problems because fluid is getting accumulated in the body. So those who have the heart failure problems, they should not be on thiazolidinediones. And then finally, the other class of the drugs are anthracycline antibiotics, doxorubicin and daunorubicin. So both the anthracyclines, these drugs, they are used, they are the anti-cancer drugs. So these drugs, they have the cardiotoxic effects. And one of the side effects of these drugs, one of the cardiotoxic effects is they precipitate the heart failure. Okay. So these are the few important drugs that may precipitate the heart failure. Okay. Now, this heart failure, it can be categorized into two types. So one is the systolic heart failure and the other is the diastolic heart failure. So systolic in the sense, systole means contraction. So in case of systolic heart failure, the cardiac muscles or the cardiac myocytes, they fail to undergo proper contraction. That is a forceful contraction. Okay. Whereas in case of diastolic heart failure, the cardiac myocytes, the cardiac muscles, they fail to undergo proper relaxation. Okay. So they won't get relaxed properly. Okay. So diastolic phase is also much important because if the muscles, they won't get, like the ventricular muscles, if they won't get relaxed properly, then the ventricles, they won't get filled with the blood. Okay, so if the ventricles are not relaxed, then the ventricular chambers won't get filled with the blood properly. If the chambers are not getting filled, then the cardiac output will get reduced. Okay. So we can categorize the heart failure as systolic and diastolic heart failure. Okay. And we can also categorize this heart failure as left-sided and right-sided heart failure based on the side of the heart which is getting affected. Okay. So which side of the heart is getting affected? Either the left ventricle or the right ventricle has got affected. Okay. So the cardinal symptoms, the main symptoms of the left-sided heart failure is dyspnea. Okay, that is shortness of breath due to pulmonary congestion. And the cardinal symptom or the main symptom of the right-sided heart failure is peripheral edema, that is ankle swelling or congestion in the liver. Okay. So how left-sided heart failure, it causes shortness of breath, okay, and how the right-sided heart failure, it leads to cause ankle edema as well as congestion in the liver. So everything that we'll study in the next slide. Okay, so with the help of a diagram, we'll come to know how left-sided and the right-sided, they lead to cause the pulmonary and peripheral edema respectively. And most of the times, the patients, they present with a biventricular failure. Okay. Biventricular in the sense they will have both left-sided and right-sided failure. So left-sided, that is the left ventricular, and right ventricular failure. Okay, so that's why we'll tell it as a biventricular failure. Okay. So now let's have a look through what is left-sided heart failure and what is right-sided heart failure, and why left-sided is causing the shortness of breath and why right-sided is causing the ankle edema. Okay. So this diagram, it represents, so here in this diagram, which is the structure of the heart, okay, so we can divide the heart into right-sided and left-sided. So this part, the bluish color part, okay, so has got the right atrium and the right ventricle, because the veins which are bringing the blood, okay, so which are bringing the impure blood, that is the deoxygenated blood. Okay, so we have got two major veins. One is the superior vena cava and the other is the inferior vena cava. So the main function of these two vena cavas is to bring or to collect the impure blood from all over, throughout the body, and they will bring that impure blood to the right atrium. Superior vena cava, it brings the impure blood from the upper part of the body, whereas the inferior vena cava, it brings the blood from the lower part of the body. Okay. So they bring the blood to the right atrium. From the right atrium, the blood enters into the right ventricle. From the right ventricle, during right ventricular systole, that is contraction, the blood which is present in the right ventricular chamber, it will get pumped into the pulmonary artery. Okay. So pulmonary artery is the only artery in our body which carries impure blood or deoxygenated blood. Okay. So the blood which is present in the right ventricle during right ventricular systole, it gets pumped into the pulmonary artery. From pulmonary artery, the blood reaches to the lungs, where it gets purified, and the purified or oxygenated blood, with the help of pulmonary veins, it reaches to the left atrium. Okay, so pulmonary veins are the only veins in our body which brings the pure blood or oxygenated blood. So now the blood reaches to the left atrium. From the left atrium, during left atrial systole, the blood enters into the left ventricle. And during left ventricular systole, that is contraction, the blood which is present in the left ventricle, it will be pumped into the aorta. Okay. From aorta, the blood enters into the arteries. Okay. And it gets circulated throughout the body. That is, the blood will enter into the systemic circulation. So this is the overall structure of the heart. So here, what we can do is, if we divide the heart into the right side and the left side, so clearly we can see that on the right side, always the deoxygenated blood gets circulated, and on the left side, always the oxygenated blood gets circulated. Okay. So now let's have a look through what happens in case of the left-sided heart failure and what happens exactly in case of right-sided heart failure. Okay. So in this diagram, again, we can represent that Okay, so at first, let's assume that the patient has got a right ventricular failure. Okay, so right ventricular failure in the sense the patient's right ventricle is not contracting properly. Okay, so the systole is not occurring properly. Okay, so as a result, what happens is the blood which is present in the right ventricular chamber, so it remains within the right ventricle. Okay, so it means that it won't get remained, like the complete blood won't get uh, resided within the right ventricle. Okay, so in case of heart failure, that is the systolic heart failure, a portion of the blood, okay, it still gets retained within the right ventricle. Okay, so the severity of the heart failure, that is the systolic heart failure, it depends on how severe the heart failure it is. That is the percentage of the blood that retains in the chambers. It depends on how much, like how severe the heart failure it is. Okay, so that everything that I will explain you in when we talk about the ejection fraction in the next slide. Okay, so now let's assume that the right ventricular systolic failure, that is the right ventricle has failed to pump the blood properly into the pulmonary artery. Okay, as a result, this the blood, it remains within the right ventricle. Okay, and that blood, it exerts a pressure on the right atrium. Okay, so as a result, the right atrium during atrial systole, the blood which is present in the right atrium, it won't enter into the right ventricle. Okay, so the blood resides within the right atrium. Okay, and as the blood resides in the right atrium, so what happens here is, so the blood which is present in the right atrium, it exerts a pressure on the blood which is present in the vena cavas. Okay, so the vena cavas which are collecting the blood, especially the inferior vena cava, which is bringing the blood from the lower part of the bodies. Okay, so it can't bring, or it can't dump the blood into the right atrium. Okay, because already the right atrial chamber is filled with the blood. Okay, so finally what happens is that the blood which is present in the inferior vena cava, so this blood will be pulled back. Okay, so it will be pulled back, that is the blood will come back to the lower limbs. Okay, and it gets accumulated, that is the plasma or the fluid gets accumulated up over there, and it leads to cause the peripheral swelling or the peripheral edema. Okay, so finally, in case of right side heart failure, if it is a right ventricular failure, okay, then the blood which is present in the inferior vena cava, okay, so the blood which is present in the inferior vena cava, it won't it won't enter properly into the right atrium, and as a result, it leads to cause the peripheral edema in the patient. Okay, the most common is the ankle swelling. So now let's have a look through the left-sided heart failure. In case if the left ventricle has failed to undergo a proper contraction, that is the systole, now what happens is, due to the failure of contraction, most of the blood, it gets retained within the left ventricular chamber. Okay. As a result, it exerts a pressure on the left atrium. So the left atrium further, it exerts a pressure on the pulmonary veins. Okay, so it means that the blood which is present, which is coming from lungs to the pulmonary veins. Okay, so actually the blood flows in this way, like from pulmonary artery, the blood will enter into the lungs. So the blood gets purified over there, and the purified blood from the lungs, it comes back through pulmonary veins. But here, due to this pressure, the blood which is present in the pulmonary veins, it won't enter into the left atrium properly. So blood gets retained here in the lungs. Okay, and it leads to cause the pulmonary congestion. That is, fluid gets accumulated in the lungs, and the patient, they develop the shortness of breath. Okay, so in this way, in case of the left ventricular failure or the left side heart failure, the patients, they will have pulmonary congestion or the shortness of breath. Okay, so right side heart failure, that is the right ventricular failure, leads to cause peripheral congestion, that is it leads to cause ankle edema, and the left side heart failure, it leads to cause the pulmonary congestion, that is fluid gets accumulated in the lungs, and the patients, they complain of the shortness of breath. Okay, so this is the major difference between the left side and the right sided heart failure. Okay, so now let's have a look through the short MCQ. Okay, the shortness of breath, which we'll tell it as the dyspnea, can be noticed in which side of the heart failure? okay, either right side or left side. So the answer is left-sided heart failure. Okay. Then the peripheral edema, especially the ankle swelling, can be noticed in which side of the heart failure, either right side or left side. So we know that peripheral edema, that is the ankle swelling, can be noticed in case of right-sided heart failure. Okay. Then now we need to know about a major factor which is known as the ejection fraction of the heart. Okay, because each and every time that when we study about the medications, especially about the digoxin and its mechanism of action and everything, so there we need to know about this ejection fraction. Okay, so we need to know what is meant by this ejection fraction. So ejection fraction is the fraction of the blood which is ejected out during each ventricular systole. Okay, so that is during left ventricular systole, left ventricular contraction, or the left ventricular systole, how much percentage of the blood is ejected into the aorta. Okay, so how much percentage of the blood is getting ejected into the aorta, that is into the systemic circulation, is known as ejection fraction. Okay, so the same thing that we also measure for the right ventricle. Okay, so how much percentage of the blood that is entering into the pulmonary artery. But the important one is the left ventricle, because this is the, like, left-sided heart failure is the most common type of the heart failure when compared to that of right-sided heart failure. Okay, so the percentage of the blood that enters into the aorta or into the systemic circulation is known as the ejection fraction. Okay? So in a normal healthy heart, okay, so the left ventricle, it pumps up to 70% of the blood. Okay, so that is 70% of the blood which is present in the left ventricle will be pumped into the aorta or into the systemic circulation. Okay, so that is the normal ejection fraction of the heart. Okay, it means that still 30% of the blood will retain inside the ventricular chamber. Okay, so that's fine. But in case of heart failure condition, what happens is, so that ejection fraction, it gets reduced. Okay, from 70%, the ejection fraction will reduce to 50%, or the ejection fraction will reduce to 40%. Okay, so the reduction in the percentage, it depends on the severity of the heart failure. Okay, so if it is reduced to 50%, then we'll tell it as, yeah, the patient has got the heart failure problem. But it has reduced to 40%, then we'll tell it as that, yeah, he has got a more severe heart failure condition. But it has reduced to 35% or 30%, then it is highly severe condition. Okay, so in this way, as the percentage of the blood which is pumped out, which is the ejection fraction, okay, so as the ejection fraction, it gets reduced, then the severity of the heart failure will classify it as the heart failure is the most, it is in much severe condition. Okay, then here, as I mentioned, that a healthy heart will eject up to 70% of the blood, 60 to 70%. But in case of systolic failure, that is, systole means contraction. So in case of systolic failure, this ejection fraction will be reduced to 40%. Okay. In severe heart failure condition, it may further reduce to 35%, but in more severe conditions, it may even reduce to less than 30%. It means that only 30% of the blood will be pumped out. Okay, which means that 70% of the blood is residing within the left ventricular chamber. So when only 30% or when only 35 or 40% is getting pumped out, the blood may not reach to all the organs in our body. Okay? So it may not reach to all the organs in our body, and the oxygen supply to all the organs in the body will get reduced. Okay? So that's the common problem that we can see in case of the heart failure. Okay, so now our main treatment goals. So what are the treatment goals for the management of this heart failure? So for the management of the heart failure, the first goal is to remove any risk factors. If there are any underlying risk factors are present, then we must try to remove those risk factors. Okay, so especially when it comes to the risk factors, as a pharmacist, so our main target, our main goal, our main responsibility is to identify if there are any medications that are causing this heart failure, or if there are any medications that may precipitate the heart failure. Okay, so that's the major role of the pharmacist. Okay? So like the patient, most of the patients, especially if they are elder patients, okay, so elder patients, they will be on many medications. They will be in a polypharmacy condition, like they will take more than 5 medications. Okay, so we need to assess properly, is there any of the medications that may leads to cause the heart failure, or that may precipitate further heart failure in the patient. Okay, so that's the one of the major roles of the pharmacist. Okay, so that's our first goal in the management of heart failure. Then the second goal is to give relief from the symptoms of congestion. So in case of heart failure, we know that the patients, if they have the right-sided heart failure, then they will have pulmonary congestion and they will have shortness of breath. And sorry, if they have left-sided heart failure, then they have pulmonary congestion and shortness of breath. And if they have right-sided heart failure, then they will have peripheral congestion, that is peripheral edema, like ankle swelling and so on. Okay, so our main target at first, we must give some relief from the congestion. So to give relief from the congestion means we must try to remove that fluid, excess fluid from the body. Okay, so the excess fluid is getting accumulated, so we must try to remove that excess fluid from the body. Then the third goal is to optimize the life prolonging therapy. Okay, so how we can improve the survival of the patient. Okay, so that is our third goal. And final goal is to promote healthy lifestyle. Like we need to ask the patient to avoid taking excess of salt and all those conditions which are non-pharmacological methods. They come under the fourth goal. Okay, so the first goal is to identify any risk factors and remove those risk factors. The second goal is to give relief from the symptoms, okay, which is the main or the first step that we need to do in case if the patient have the congestion. And then the third goal is to promote the life prolonging therapies. And then the fourth goal is to promote a healthy lifestyle to the patient. Okay, so now let's have a look through how we can achieve these goals. Okay, so this is an overall classification of the drugs that can be used for the management of heart failure. Okay, and our goals that we have seen in the previous slide, we can achieve through these medications. Okay, so to relieve the congestion means to remove that excess fluid from the body. Okay, so what we can do is we can give diuretics to the patients. Okay, so providing diuretics to the patients is the best method through which we can remove that excess fluid from the body. Okay, and the diuretics that we use here are the loop diuretics. Okay, not the thiazide or any other class of the diuretics. Okay, so loop diuretics will provide, like loop diuretics are the diuretics that helps to remove that excess fluid from the body, and they help to provide some relief from congestion. Okay, so the examples for the loop diuretics are furosemide, bumetanide. Okay, and then, however, in the next slide we will see the complete classification of the diuretics as well. Okay, then the next goal, as we have seen in the previous slide, so the first goal is to identify and remove the risk factors. Okay, so that this goal we will study in detail in the form of a case study at the end. Okay, then our second goal is to provide relief from symptoms of congestion. And in order to relieve the symptoms of congestion, we can give diuretics to the patient. And then our next goal is to optimize life prolonging therapies. And to optimize the life prolonging therapies, so what we can do is, so we can give some medications. Okay, so we can give certain drugs that can arrest or reverse the disease progression. So these are the drugs that they prevent further disease progression, and also they help to prolong the survival of the patient. They help in increasing the life of the patient. So the examples for the drugs are, the first one is the ACE inhibitors, captopril, enalapril, ramipril, lisinopril, perindopril. All are the examples for the ACE inhibitors. And if ACE inhibitors are contraindicated, then we can go with ARBs, angiotensin converting angiotensin 2 receptor blockers, candesartan, losartan, okay, edbisartan. All are the examples for the ARBs. And we can also achieve this goal by giving beta blockers to the patients. So the three main beta blockers that we use in heart failure are bisoprolol, metoprolol, and carvedilol. Okay? So BMC, bisoprolol, metoprolol, and carvedilol. So these three are the beta blockers that we use in heart failure. So we won't use other beta blockers in the management of heart failure. And the next class of the drugs are aldosterone antagonists. They are also known as potassium-sparing diuretics. Examples are spironolactone and eplerenone. So we can also use spironolactone and eplerenone. So these drugs, they also have the property to prevent further disease progression, and they can prolong the survival or the life of the patient. And the last one is, it is a recent drug. Like recently they have introduced into the market, like 5-6 years back. So that is the neprilysin inhibitor with sartan combination. Okay, that is sacubitril with valsartan. So this sacubitril with valsartan, this drug, it should be given only at the last stage, like when ACE inhibitor plus beta blocker and other drugs combination, they fail to show improvement, then only the doctors, they will put the patient on sacubitril with valsartan. But before putting the patient on sacubitril with valsartan, so what we need to do is we must stop ACE inhibitor, okay, or ARB. So ACE inhibitors are one of the first line drugs in heart failure management. Okay, so heart failure patients, they must be on ACE inhibitor. So this is one of the first and the most important drug. The patient must be on ACE inhibitors. At the same time, they must also be on beta blockers. So ACE inhibitors and beta blockers. So these two classes of the drugs are, like all the heart failure patients, they must be on these two classes of the drugs, ACE inhibitors and beta blockers. And if ACE inhibitors are contraindicated, like the main contraindication for ACE inhibitor is once after starting the ACE inhibitor, if the patient develops dry cough, because one of the main side effects of the ACE inhibitors is ACE inhibitors, they cause the dry cough. If the patient develop the dry cough, then we can switch the patient from ACE inhibitor to ARBs. So let's say, for example, initially the patient is on enalapril, and after using enalapril, the patient has developed the dry cough. Then what we can do is we can stop enalapril and put the patient on any one of the sartans. So finally, patient with heart failure, they must be either on ACE inhibitor or ARBs plus beta blocker. Okay. ACE inhibitor plus beta blocker, or a combination of ARB plus beta blocker. Okay. So let's assume that the patient is already on ACE inhibitor, that is enalapril with bisoprolol combination. So even with these two drug combination, the patient's symptoms are not getting improved. Then only the doctors, they will decide to switch over to sacubitril with valsartan. But before switching over to sacubitril with valsartan, so what they will do is they will ask the patient to stop taking this enalapril. Okay. So they will ask the patient to stop taking enalapril, and after stopping the enalapril, the patient must wait at least 36 hours. Okay. Or ideally, we will ask the patient to wait for 2 days, okay, to start using sacubitril with valsartan combination. So in the market, it is available with a brand name known as the Entresto. So it means that before starting the Entresto, the patient must stop taking whatever be the drug the patient is using, either ACE inhibitor or ARB. Okay, so the patient must stop this drug and then wait for 36 hours, and after 36 hours they can use this combination. So here what happens in case if the patient has already took the morning dose of enalapril And in the evening, the patient took this sacubitril with valsartan combination. That is the Entresto tablet. Okay. So what happens here is there will be a high risk of hyperkalemia, okay, and there will be a high risk of angioedema. So if the patient takes ACE inhibitor and this new drug, that is the combination drug, both together, then the risk of hyperkalemia and angioedema will be severe. Okay. So to avoid, because one of the common side effects of ACE inhibitors is they cause hyperkalemia. They increase the serum potassium levels. The same side effect goes with ARBs as well. Candesartan, losartan, irbesartan, okay, telmisartan. So all these drugs, they also have got the same property. They also increase the serum potassium levels. So here already there is a valsartan. Okay. Valsartan is nothing but it is also a type of sartan. It is also an angiotensin 2 receptor blocker. So if we combine valsartan with ACE inhibitor both together, or if we combine valsartan with irbesartan both together, then the risk of severe hyperkalemia and angioedema will be higher in the patient. So that's why the patient must stop taking ACE inhibitor or ARB, so and need to wait at least 36 hours to start using this new drug. So all these drugs, either ACE inhibitors, ARBs, beta blockers, and aldosterone antagonist. So this aldosterone antagonist, actually this drug, spironolactone and eplerenone. So both the drugs, like we can put the patient on aldosterone antagonist. Okay? So only when ACE inhibitor and beta blocker combination is not showing much response, then the doctors, they will decide to put the patient on spironolactone. So the therapy, it starts in this way. So at first they will put the patient on ACE inhibitor. And after putting the patient on ACE inhibitor, beta blocker is also a mandatory. It is a compulsory drug. They also start the patient on a beta blocker. Okay. So ACE inhibitor plus beta blocker combination. So even on this combination, after a few months, if the patient still complains about this heart failure symptoms, then what they will do is they will add another drug, that is aldosterone antagonist, that is spironolactone. So one of the main side effects of this spironolactone is it causes gynecomastia because it suppresses the androgen levels in the body. So in males, it leads to cause the gynecomastia. So in case if that is the problem, then what they will do is they will switch over from spironolactone to eplerenone. So eplerenone is the drug which is free of such side effects. The main advantage of the eplerenone is eplerenone will have lesser side effects when compared to spironolactone. Okay. So that's why in case if the patient has developed any of the spironolactone related side effects, then they will switch the patient over to eplerenone. But first they will try with spironolactone. The reason is spironolactone is less expensive when compared to eplerenone. Okay. So all these drugs, their main function is they prevent further disease progression and they prevent further damage to the heart, and they help in prolonging the life of the patient. Okay. Whereas the first class of the drugs, diuretics. So diuretics, they won't help in prolonging the life of the patient. They won't help in preventing the disease progression. So the diuretics only role, the main function of the diuretics is just to remove the fluid from the body. Okay. So their only function is to remove that congestion, to give relief from congestion, to remove that excess fluid from the body. So that's the only function of the diuretics. And then the last class of the drug is the drugs that improve the cardiac output. So we know that the most famous drug in case of heart failure is digoxin. So digoxin is the drug that has got a positive inotropic property. Inotropic, as already I mentioned, inotropic means increase in the force of contraction. So digoxin will increase the force of contraction. Okay. So here, the important point that we need to know is digoxin is the drug that helps to improve the cardiac output, okay, only to improve the cardiac output, okay, because it has got a positive inotropic effect. But digoxin, it it won't reverse or it won't prevent further disease progression. Okay? So digoxin's only function is to pump the blood. Okay? So to pump the blood out from the ventricles, it increases the force of contraction of the ventricular myocytes, that is the ventricular muscles. So that's the only function of the digoxin, but digoxin, it won't help to prevent further disease progression. Okay. So in detail about each class of the drugs that we'll have, that we need to go through it, and how these drugs, they show the action. So that we'll study in the next slides. Okay. So this is an overall classification of the drugs that can be used for the management of heart failure. Okay. So now, the first class of the drugs are the diuretics. So diuretics, as already we have studied regarding this diuretics in detail in hypertension topic. So I'm not going to go in detail about all the diuretics, each and every diuretic here. Okay. So the most important diuretic that we need to emphasize for our present topic is the high ceiling diuretics. They're also known as high efficacy diuretics, or they're also known as loop diuretics, because these drugs, they show the action at the Henle's loop. Furosemide, which is the most common drug. So whenever the patients, they have the fluid accumulated in the body, either because of the heart failure condition or because of hepatic cirrhosis, okay, or any condition, the patient have a fluid accumulated in the body, then the first drug that we will give to the patient is the furosemide. So it removes the excess fluid from the body. So in case of congestive heart failure, loop diuretics are the main drugs which helps to remove that excess fluid from the body. So we emphasize only on the loop diuretics in this topic. And there are also other diuretics like thiazide diuretics, hydrochlorothiazide, chlorthalidone, metolazone, interpamide. Okay. But thiazide diuretics, they are known as a weak, like they are moderate diuretics. They are not that too strong to remove the excess fluid from the body. Okay. So that's why we won't give only thiazide diuretics in case if the patient has the pulmonary congestion or ankle edema, such symptoms, then we can't treat with thiazide diuretics. So the best drugs to treat is the loop diuretics. And there are also other class of the drugs which are known as the weak diuretics. Estrazolamide, which is a carbonic anhydrase inhibitor. So we know that estrazolamide is the drug that can be used in glaucoma. Already we have seen its mechanism of action, everything in the previous topics. And potassium sparing diuretics, aldosterone antagonist. So this is the one, again, the spironolactone, it plays a major role in heart failure condition. So spironolactone and eplerenone, so both the drugs, they show a major role in heart failure. So how these drugs, they show the action, so that already we have seen in the previous slide. That is the aldosterone antagonist, spironolactone and eplerenone. They are also known as potassium sparing diuretics. So they prevent further disease progression and prolong the survival of the patient. And then finally, the osmotic diuretics. So we are not going to cover about the osmotic diuretics here. Mannitol and glycerol. Osmotic diuretics are mainly used in to reduce the intracranial pressure or to reduce the intraoptic pressure. Okay. So here in this slide, we can have a look through the mechanism of action of diuretics. So we are not going to cover through all the classes of the diuretics. So the only diuretic that we are going to emphasize here is the loop diuretics. Okay. So loop diuretics like furosemide, it shows the action on the Henle's loop. So mainly at the ascending limb of the Henle's loop, which contains the sodium potassium chloride pump. So loop diuretics will block this pump. As a result, sodium won't get reabsorbed. Potassium won't get much of the potassium chloride, they won't get reabsorbed into the systemic circulation. So if sodium won't get reabsorbed, then osmosis won't occur. Okay? And if osmosis won't occur, then water won't enter into the plasma or into the fluid. Okay? So ultimately, we can reduce the blood volume. So the water which is present inside the lumen of the nephron, so this water or the fluid which is present inside the nephron, so the fluid will get excreted out. So in this way, loop diuretics, they try to remove the excess fluid from the body. Okay. So now, here are the examples of the loop diuretics. That is the high ceiling diuretics, are also known as the high efficacy or the loop diuretics. Furosemide, which is the strong diuretic. Okay. So high ceiling diuretics like the furosemide are to be used only in case of the fluid overload. So whenever the patient has got the congestive heart failure or renal failure, and in hepatic or in the liver cirrhosis conditions, so during all those conditions, so we need to put the patient on the loop diuretics, because loop diuretics will help to remove that excess fluid from the body. So furosemide, the dose of furosemide, it ranges from 20 milligram and it may go even up to 500 milligram daily. Okay. So in hospital setups, once the patient, they get admitted in the hospitals with severe heart failure conditions, and when they have the shortness of breath due to fluid accumulated in the lungs, so in that condition, the doctors, they may also put the patient on a higher dose, that is up to 500 milligram of furosemide. And it is also available in the form of the intravenous drug, IV furosemide. So the dose, it can range from 20 milligram, 40 milligram, 80 milligram, 160 milligram, 250 milligram, or even up to 500 milligram daily. Okay. But always remember that when we put the patient on a higher dose of furosemide, our main target, our goal is to reduce the dose of the furosemide and bring it back to as low as possible. Okay. So let's say, for example, if you are starting, if you are trying to put the patient on 160 milligram of furosemide, then what the doctors, they will advise the patient is to come and visit the patient within a couple of weeks, like within 2 weeks. Then again, they will reassess the patient and they will reduce the dose to 80 milligram. If there is further improvement in the symptoms, then they will reduce from 80 to 40. And again, they will ask the patient to revisit after 1 or 2 months. So if there is still further improvement, then they will cut down the dose to 20 milligram. So it means that always we must try to bring back the furosemide dose to as low as possible. So we should not put a patient on a high dose of furosemide for a long term. Okay, because if long term, if the patient is on a higher doses of furosemide, then furosemide's only function is to remove that excess fluid from the body. It causes the diuresis. It removes the excess fluid from the body. So the patient becomes hypovolemic. So that's the major risk associated with furosemide. And also furosemide, it causes a lot of mineral abnormalities in the body. It causes hypomagnesemia, it causes hyponatremia, it causes hypokalemia, that is decrease in the potassium levels. And also it causes hypocalcemia, that is decrease in the serum calcium levels. So all those are the major side effects that are associated with furosemide. So that's why we must try to put the patient at a very low dose of furosemide. And if the patient's symptoms are completely improved, then we need to stop, that is de-prescribe the furosemide. Now, the uses of the furosemide or any of the high ceiling diuretics is they can be used in edema. Whenever the patient has the swelling, then we can give furosemide to the patient to remove that excess fluid from the body, and in acute pulmonary edema as well. Okay, so whenever the fluid gets accumulated in the lungs, then even sometimes we can go with the intravenous furosemide to remove that excess fluid from the body, which gives relief to the patient. Then the adverse effects of the diuretics. So diuretics, they cause the hypokalemia. As already we have covered all these adverse effects in our previous topics. So diuretics, they cause the hypokalemia, that is they decrease the serum potassium levels. And loop diuretics, only loop diuretics like furosemide, it has got an ototoxic property, especially when we combine furosemide with another ototoxic drug. The best example is aminoglycoside antibiotics, okay, like gentamicin, amikacin. Okay, so all are the examples for aminoglycoside antibiotics. So when we combine furosemide with aminoglycoside antibiotics, then the risk of ototoxicity, that is hearing loss, okay, will be more severe. Then the other side effect is allergic reactions, because furosemide in the structure, it contains sulfur in it. Even thiazide diuretics, they contain sulfur in it. Okay? So due to the presence of sulfur, these drugs leads to cause the photosensitivity reactions and skin rashes. And hyperuricemia. So these drugs, they increase the uric acid levels and they may precipitate gout in the patient. So all these are few of the adverse effects that are associated with the diuretics. Okay. Then the next class of the drugs are ACE inhibitors. Okay. So far, what we have done is, I'm going back to the previous slide. So this is the slide which represents all the classes of the drugs which can be used for the management of heart failure. Okay. So the first class of the drug is the drugs which gives relief from congestion. Okay. The best example are the diuretics. So we have covered about diuretics. Okay. And then the next drugs are the drugs that prevent further disease progression, or the drugs which improve or they prolong the survival of the patient, are ACE inhibitors, ARBs, beta blockers, aldosterone antagonist, and sacubitril valsartan. So we are going to cover about these drugs now. So ACE inhibitors, captopril, enalapril, ramipril, lisinopril, perindopril, all are the examples for ACE inhibitors. So we know the mechanism of action of ACE inhibitors. They mainly block the angiotensin converting enzyme. By blocking the angiotensin converting enzyme, they prevent the formation of angiotensin 2. Okay. So the advantages of using the ACE inhibitors are, ACE inhibitors, especially in heart failure, they prevent cardiac remodeling. So cardiac remodeling is a condition where cardiac myocytes, that is the cardiac muscles, after myocardial infarction, that is after heart attack, or after congestive heart failure, that is heart failure, our current topic. Okay. So cardiac myocytes, they change in their size, they change in the mass, and they change in the function. Okay. So their size, shape, and the function will be changed. Okay. So for, ultimately or finally, it leads to cause a decrease in the function, and it leads to cause a decrease in the function of the ventricles, and it may lead to cause the ventricular arrhythmias in the patient. Okay. So that condition is known as the cardiac remodeling. So I will explain you in detail with the diagram in the next slide. Okay. And by putting the patient on an ACE inhibitor, so if a patient has the heart failure problem, and if we put the patient on the ACE inhibitor, then these ACE inhibitors, they prevent such cardiac remodeling. That is, they prevent change in the size, shape, mass, and the functions of the heart. So if that changes occurs, then the heart will develop a new problem, which is known as the arrhythmias. So from heart failure condition, the patient will end up with another problem, and that problem is known as the cardiac arrhythmias, ventricular arrhythmias. Okay. And so that's the main reason why we must put the patient on ACE inhibitors. And then the ACE inhibitors, they also enhance the renal blood flow, they improve the renal blood flow. So, and ACE inhibitors, they prevent the diabetic nephropathy. So that's the another reason why in all the diabetic patients, the main drug of choice. Okay, so the main drug of choice is they put the patient on ACE inhibitors. So ACE inhibitors are considered as the first line agents in diabetic patients, because ACE inhibitors, they prevent diabetic nephropathy in the patients. And then ACE inhibitor, they have a capacity to regress left ventricular or the vascular hypertrophy. So ACE inhibitors are considered as the first line drugs in patients with myocardial infarction, congestive heart failure, or coronary artery disorders. So as already we have covered in our previous topics, so whenever the patient have any of the other cardiovascular problems, so if a patient is a if a patient is a hypertensive patient, along with hypertension, if the patient has any other problems like myocardial infarction, that is heart attack, or congestive heart failure, okay, or angina pectoris, so any other problems, then ACE inhibitors are to be considered as the first line agents in the patient. Okay. Now, regarding the ventricular remodeling, that as we have seen here, ACE inhibitors, they prevent cardiac remodeling. Okay, so that is ACE inhibitors, they prevent the left ventricular hypertrophy. So what is meant by this cardiac remodeling? What is meant by the left ventricular hypertrophy? So in this diagram, we can have a look through this diagram. Okay, so this is the normal size of the heart, normal shape of the heart. So here in this normal heart, so we can see the size of the left ventricle. But here on the right hand side, you can see the left ventricle has undergone hypertrophy, that is the enlarged in size. So what happened here is, here the left ventricular size, shape, and ultimately the function has been changed. Okay, so the size, shape, and its function has been reduced. Okay, so the size and shape have increased and its function has been reduced. Okay, so what happens exactly here is, so let's assume that now this patient with a normal heart, okay, so normal left ventricular size, so this patient has developed heart failure problem. So heart failure problem in the sense, initially his ejection fraction, the ventricular ejection fraction, instead of 70%, it has dropped to 55%. So during that stage, if the patient won't take ACE inhibitors, regularly, then after few months or after 1 year, what happens is his ejection fraction will further drop from 55 to 45 or 40%. And at the same time, his left ventricle, it changes its shape. So the left ventricle will undergo hypertrophy, that is, it will increase in the size. And once it increases in the size, so it loses its elastic contractile property. Okay, so that's what we'll study in case of Frank Sterling's law. When a rubber band is stretched, okay, it will recoil, it will come back to normal size. But if we stretch the rubber band to a larger extent, or if we keep on stretching the rubber band to larger extent for more than like 5 to 10 minutes, then what happens? That rubber band, it loses its recoiling property. It won't recoil. It won't come back to its normal size. So that's what it happens with the left ventricle. It has got completely stretched. So it means that it won't undergo a forceful contraction. The muscles, the cardiac myocytes, they won't recoil properly. They have lost their elastic recoiling nature. Okay, so that's what it happens if we won't put the patient on an ACE inhibitor. If the patient won't take the ACE inhibitors, in long term, it leads to cause the cardiac remodeling. So ACE inhibitors, they prevent the cardiac remodeling. So not only ACE inhibitors, but also beta blockers. Beta blockers are also one of the most important drugs in heart failure. So beta blockers also, they prevent such cardiac remodeling. And not only the beta blockers, even spironolactone, which is a aldosterone antagonist, it also shows the same property. It also has the same property. That is, it prevents cardiac remodeling. That is, it prevents left ventricular hypertrophy and prevents the development of further cardiac arrhythmias. So why arrhythmias develop here? What is the reason why the heart rate will increase? So the reason here is, okay, so here you see the left ventricle has enlarged. It has undergone hypertrophy. It has got enlarged. So it means that this left ventricle has failed the forceful contracting property. It is not undergoing a proper systole, that is contraction. So when it is not undergoing a proper contraction, then obviously the blood won't be pumped out into the aorta properly. Only 35% of the blood is, let's assume that only 35% of the blood is pumping out. Instead of 70%, only 35% is pumping out. That is, it has dropped up to 50% of the total ejection fraction. So only 35% of the blood is pumping out. So now what happens is, due to the lack of proper oxygen supply to the tissues, okay, so as only 35% of the blood is pumping out, only 35% of the blood is reaching to all the organs of the body. So less oxygen is reaching to all the organs in the body. Then immediately the sympathetic system gets activated. Sympathetic system will recognize that low blood flow, okay, and sympathetic system will activate and it will keep on releasing noradrenaline. Okay, so it will keep on releasing noradrenaline. So we know that once the noradrenaline is released, noradrenaline will show the action on the beta-1 receptors on the heart. Okay? And once the beta-1 receptors get activated with more noradrenaline, then the heart rate will increase. Okay? So heart rate will keep on increasing. So it will keep on increasing from 70 beats per minute, which is normal heart rates, 70 to 80 beats. From there, the heart rate, it may go up to 300 beats per minute or 400 beats per minute. Okay, so that condition is known as the arrhythmias, ventricular arrhythmias, ventricular tachycardias. Okay, so which may lead to cause the death of the patient again. Okay. So that what it happens. Okay, so if left ventricle, if it undergoes the hypertrophy, then obviously the cardiac output will decrease. When the cardiac output is decreased, then sympathetic system will get overactivated. Now the sympathetic system will keep on releasing noradrenaline, and that noradrenaline will increase the heart rate, and that heart rate, sometimes it may go even up to 400 beats per minute. That is, the left ventricular fibrillation occurs, and it leads to cause the death of the patient. Okay, so that's why if we put the patient on a ACE inhibitor, and if we put the patient on a beta blocker, or if we put the patient on a spironolactone, then all these drugs, they prevent such cardiac remodeling, or they prevent ventricular hypertrophy. Okay, so by preventing all those conditions, they prolong the life of the patient, they prolong the survival of the patient. Okay. So ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, so all these drugs, they prolong the survival of the patient. Okay. Now, this is the mechanism of action of ACE inhibitors. As we all know about this mechanism, we have studied many times. So ACE inhibitors, they mainly prevent the conversion of angiotensin 1 to angiotensin 2. Okay. So that's the mechanism of action of ACE inhibitors. Now, regarding the side effects of ACE inhibitors. So the first side effect is hyperkalemia. They increase the serum potassium levels. Whereas we know that diuretics, they cause hypokalemia. Diuretics, they decrease the serum potassium levels. And the second adverse effect of the ACE inhibitors is ACE inhibitors, they cause the rash and angioedema. And ACE inhibitors, they also cause the dry cough. So angioedema, dry cough, rash, all these side effects are due to increase in bradykinin levels in the body. So when we put the patient on ACE inhibitors, so what happens is ACE inhibitors, they block they prevent the hydrolysis or the degradation of bradykinins in the body. As a result, the bradykinin levels gets increased. So due to increase in the bradykinin levels, it leads to cause dry cough, angioedema, and rash and other problems in the patient. And ACE inhibitors, they increase the serum creatinine levels. So increasing the serum creatinine levels is quite common. So whenever we put the patient on ACE inhibitors, then their serum creatinine level will definitely increases. So this increase is common, and increase up to 25% is acceptable. Okay? So up to 25% is acceptable, but if it keeps on increasing beyond that, then we need to stop giving ACE inhibitors to the patient. And all the ACE inhibitors are contraindicated in pregnancy. So we should never give ACE inhibitors in pregnant women. Then ARBs, that is the angiotensin 2 receptor blockers. So ARBs, losartan, candesartan, irbesartan, telmisartan. So all these drugs, they share the same properties as that of the ACE inhibitors. They share the same side effects. They share the same properties as that of ACE inhibitors, except dry cough. ACE inhibitors, they cause the dry cough, whereas ARBs, they won't cause any dry cough. And in patients, those who develop the dry cough with ACE inhibitors, then the doctors, they will switch them over to the angiotensin 2 receptor blockers. Okay. Now, the next class of the drugs are the beta blockers. So beta blockers, examples are bisoprolol, metoprolol, carvedilol. Okay. So these beta blockers, only BMC, that is bisoprolol, metoprolol, and carvedilol, are the drugs that can be used in heart failure. Okay. And that too, metoprolol, not the immediate release, only the sustained release metoprolol is the drug of choice in heart failure. Okay. Then always beta blockers are to be used in combination with ACE inhibitors in the management of heart failure. And these two drug combinations, ACE inhibitors plus beta blocker combination, is considered as a first-line agents in the management of heart failure. Okay. If ACE inhibitors are contraindicated, we can replace it with ARBs, ARB plus beta blockers. These two combination is considered as the first line in heart failure. And the most important point here is we should not initiate a beta blocker until the patient is stable, that is hemodynamically the patient is stable, or we should not give a beta blocker to the patient when the heart is in a decompensated state. Okay. So we need to start giving the beta blocker only when once the heart, it comes back to a compensated state. Okay. So it means that when that excess fluid which is present in the body, it should be removed out from the body first, then only we need to start the patient on a beta blocker. Okay. So what happens if the heart is in a decompensated state, and on top of that, if we start beta blocker to the patient, okay, then we know that beta blockers, they also have got a negative inotropic property, that is they reduce the force of contractions. Okay. So as a result, the patient heart cardiac output will further decrease, the patient becomes hypotensive, and other complications will arise. So that's why beta blockers are life-saving drugs. Of course, they are the life-saving drugs, but we should not start the beta blockers like abruptly. We should not start the beta blockers. So we need to start a beta blocker carefully when once the heart, it comes back to a compensated condition, or when once that excess fluid is removed from the body, or when once the patient is hemodynamically stable, then only we need to start the patient on a beta blocker. Now, the advantages of the beta blockers are again the same. Beta blockers also prevent the cardiac remodeling. That's what we have seen with ACE inhibitors. Okay. And the beta blocker, they have a capacity to prevent or to regress left ventricular or the vascular hypertrophy. So that's why beta blockers are considered as the first line drugs in patients with almost all the cardiovascular problems. Like if the patient has hypertension with myocardial infarction, hypertension with congestive heart failure, hypertension with any coronary artery disorders, like angina pectoris, okay, then beta blockers are to be considered as the first line agents, because beta blocker, they have a cardioprotective property. Okay. Then the next class of the drugs are the aldosterone antagonist. The examples for aldosterone antagonist are spironolactone and eplerenone. So these two drugs are aldosterone antagonist. Now, why do we need to give this aldosterone antagonist? So first of all, what is aldosterone? So aldosterone is the hormone which is released by the adrenal gland, adrenal cortex. It releases the mineralocorticoid, and the name of that mineralocorticoid is known as the aldosterone. So its name itself, it indicates that it is a mineralocorticoid. So its major function is it keeps on reabsorbing the sodium and water into the body. So aldosterone, it reabsorbs the sodium and water at the collecting duct of nephrons into the systemic circulation, that is into the bloodstream. So as a result, aldosterone, it increases the extracellular fluid volume, it increases the cardiac preload. And aldosterone, It also causes the fibrotic changes in the myocardium, like worsening of the systolic dysfunction and pathological remodeling. Again, when aldosterone keeps on acting on the heart, it leads to cause the cardiac remodeling. That is, left ventricular hypertrophy may occur with the continuous action of the aldosterone in the body. So what happens here is, if we give an aldosterone antagonist, okay, so that is the spironolactone, which is a weak diuretic, and it is also a potassium sparing diuretic. Okay? So if we put the patient on aldosterone antagonist, then the aldosterone antagonist will block these functions. And aldosterone antagonist, that is the spironolactone, will prevent the left ventricular hypertrophy. Okay? So that's the advantage of aldosterone antagonist, that is spironolactone. Okay? And the main drawback or the side effect of the spironolactone is they cause the hyperkalemia, because the name itself, it indicates that they are potassium sparing diuretics. They reabsorb the potassium they conserve more potassium into the body. Okay, so serum potassium levels gets increased and the patient become hyperkalemic. And spironolactone, it also has got another major side effect, that is gynecomastia. So eplerenone is the drug which is free of this side effect. So whenever the patient they develop any gynecomastic symptoms, then we need to switch the patient over to the eplerenone. So that's about aldosterone antagonist, that is the spironolactone. And again, when do we need to use this aldosterone antagonist? That is when we need to give spironolactone to the patient. So spironolactone is to be given to the patient when the combination of ACE inhibitor and the combination of the beta blocker, both the drug combinations, when they fail to show the action, then we will add spironolactone to the therapy. Okay. So right at the beginning, like, we won't give spironolactone as the first line agent. So we always reserve the spironolactone when once the combination of ACE inhibitors and the beta blockers, they fail to show proper improvement, then we will add the spironolactone. Then the next class of the drug, the last one and the most important one, is digoxin. So digoxin, it is a cardiac glycoside. Okay? So we know that digoxin, it has got a positive inotropic property. So it means that it increases the force of contraction. And the main mechanism of action of the digoxin is it shows the action at the sodium potassium ATPase pump. So it shows the action at that pump, and it indirectly it increases the calcium levels, and due to the increase in the calcium levels, it leads to cause contractions in the cardiac myocyte. So in this diagram, we can have a look through the mechanism of action of digoxin. So digoxin, it shows the action at the sodium potassium ATPase pump. So this pump is the sodium potassium ATPase pump. So digoxin, so first of all, let's have a look through what is the function of this pump. So through this pump, there will be 3 sodium ions, the intracellular sodium ions. 3 intracellular sodium ions will get effluxed out, and in exchange to that 3 sodium ions, 2 potassium ions will influx into the cell. Okay, so 3 sodium gets effluxed out and 2 potassium will enter into the cell. So this is the function of the sodium potassium ATPase pump. Now, digoxin, if we give the patient digoxin, then digoxin will go and bind to this pump, and digoxin will block this pump. So when this pump is blocked up, then the intracellular sodium, it won't get effluxed out. Okay. As a result, the sodium concentration within the cell gets increased. When that sodium concentration gets increased, we know that in order to develop an action potential, the main ions which are required are sodium ions. So when that sodium concentration is getting increased, then an action potential will develop. And these sodium ions, they also stimulate the calcium ions which are stored inside the sarcoplasmic reticulum. So they also stimulate the calcium ions. Sorry, they also stimulate the release of calcium ions from the sarcoplasmic reticulum. And when once these calcium ions are released, the calcium ions, they bind with the actin and myosin filaments. And when once they bind with the actin and myosin filaments and forms the cross bridges between actin and myosin filaments. As a result, it leads to cause the contraction of the cardiac myocyte. So in this way, digoxin indirectly, it is increasing the calcium levels, which helps in contracting the cardiac muscle. So digoxin, it causes the positive inotropic property. That is, it helps in increasing the force of contractions. And there are two things that mainly interacts with the digoxin. One is the potassium levels. Okay, so and the like the potassium levels, we can categorize it into increase in serum potassium and decrease in serum potassium levels. Okay, so these two are the factors that mainly they interact with the serum digoxin concentration. So increase in serum potassium levels is known as hyperkalemia, whereas decrease in serum potassium levels is known as hypokalemia. Okay, so what happens exactly here is, so digoxin and potassium, they both fight together to bind with the sodium potassium ATPase pump. Okay, so if digoxin levels are more, okay, if digoxin is stronger, then digoxin will bind with this pump and it blocks the sodium potassium ATPase pump. It means that digoxin will prevent the efflux of the sodium ions. But on the other hand, if potassium concentration is higher, okay, so in case of hyperkalemia, what happens here is potassium will fight with digoxin. Okay, and as we know that potassium levels are higher, potassium will win. Okay, so it will bind with the pump and potassium will get influxed and sodium will come out. It means that in case of hyperkalemic condition, the digoxin's therapeutic effect will get decreased. Okay, so in case of hyperkalemia, the digoxin's therapeutic effect will decrease. On the other hand, in case of hypokalemia, that is when potassium concentration is low. So now what happens here is digoxin will bind, okay, and more amount of the digoxin will bind and digoxin will keep on showing the action, and it may go to it, or it may reach to toxic levels. Okay, so hypokalemia will lead to cause excess digoxin of action, and sometimes it may also show the toxic effects of digoxin, whereas hyperkalemia will decrease the digoxin actions, okay, and it shows the subtherapeutic effect of digoxin. Okay, then this is the most important thing that you guys need to know regarding digoxin. So the accepted therapeutic range of digoxin is 0.5 to 2 micrograms per liter. But ideally, so in most of the elder patients and those who have this renal impairment issues, okay, so our target range will be 0.5 to 0.8 micrograms per liter. Because in most of the cases, when once the serum target levels, the digoxin target levels, even if it reaches to 1.2, then immediately the patient, they will start showing the side effects, the toxic effects of digoxin. So that's why we'll never target up to 2. Okay, so always our target is 0.5 to 0.8 micrograms per liter. Now, let's have a look through what are the toxic effects of this digoxin. So when once the digoxin levels, that it reaches to the toxic range, that is, even if it goes up to 1.2, then immediately the patients, they will start developing the symptoms, okay, the toxicity symptoms. And the main toxicity symptoms, the first symptoms that can be seen are the gastrointestinal symptoms. Okay, so the gastric symptoms are the first symptoms, like nausea, anorexia, vomiting. So these are the first signs of digoxin toxicity. And after developing the gastrointestinal symptoms, later the patient will develop the cardiac symptoms, like cardiac arrhythmias. Okay, so these are the common toxic side effects of digoxin. And usually the digoxin's steady state concentration will be reached after 7 days. In case if the patient has a normal renal function, then it takes at least 7 days to reach the steady state concentration. Okay, and in case if the patient has the renal impairment, then it may take longer time. Okay, instead of 7 days, it may go even up to 14 days or 15 days to reach the steady state concentration. Okay, So the half-life of digoxin is 36 hours. And for any drug to reach the steady state concentration, it needs at least 4 to 5 half-lives. Okay, let's take 5 half-lives. 5 times 36 hours. Okay, roughly around, it takes 7 days for the drug to reach the steady state concentration. So it means that we measure the therapeutic levels of digoxin. We'll take the sample and measure the digoxin levels only when once the digoxin reaches the steady state concentration. So before that, we should not measure the steady state concentration of digoxin. Okay, and that too, we need to take the blood sample at least 6 hours after the dose to allow proper distribution of the digoxin. So after giving the digoxin dose, we need to wait at least 6 hours for the drug to get distributed. Then only we need to collect the serum sample. So these are few important points that are related to the digoxin, and all these points are mainly related to the target or therapeutic range of digoxin. Okay. So finally, this is the overview of the topic, guys. So from this slide, we can come to know that what class of the drugs are to be considered as the first-line agents in the management of congestive heart failure. So whenever the patient, they present with heart failure problems, heart failure symptoms, so the first-line drugs that we need to give to the patient are the ACE inhibitors, okay? Like enalapril, lisinopril, ramipril, perindopril, all are the ACE inhibitors. If ACE inhibitors are contraindicated, then we can give ARBs. Okay? But ACE inhibitors or ARBs are considered as first-line agents. And along with ACE inhibitors, so we must also give beta blockers to the patient. Always we must combine beta blockers with ACE inhibitors. And the most important point that I mentioned earlier was, so we should not give beta blocker to the patient when the heart is in a decompensated state. So we need to wait until the heart comes back into a compensated state. Okay? Then we can start the patient on a beta blocker. Okay. So ACE inhibitors and beta blockers, these two are the mandatory drugs. Then diuretics. So diuretics, they also play a major role in heart failure. So diuretics are to be given only when required. Whenever the patient has congestion or whenever the patient has the fluid overload, then only we'll give diuretics to the patient. Okay. Otherwise, we won't give diuretics to the patient. Then spironolactone. Spironolactone, which is an aldosterone antagonist, okay, and it is also a potassium-sparing diuretic. So this spironolactone is to be added to the initial therapy. Initial therapy in the sense a combination of ACE inhibitor and beta blocker therapy. So spironolactone is to be added to the initial therapy where the first-line agents, they fail to show improvement in symptoms. So here the first-line agents are ACE inhibitors plus beta blocker combinations. So if they fail to show the improvement in the symptoms, then we can put the patient on spironolactone. And always digoxin. Digoxin is always considered as the last option where the ejection fraction is too low, okay, or there is a minimal response with the initial therapy, then only we need to put the patient on digoxin. Okay. So because we know that digoxin, it won't help in prolonging the survival of the patient. Okay. And in long term, if we put the patient on a digoxin for a long term and at the higher doses, then what happens is, so the only function of the digoxin is to improve the pumping of the heart. So that's the only role of digoxin. It will keep on increasing the force of contractions. So it will keep on increasing the pumping of the heart. Okay. So what happens is, in long term, like if the patient is on digoxin at a higher doses for a long term, that is for 2 years or 3 years, then what happens is after pumping, like after continuous systoles or the continuous increase in positive inotropic property, so the ventricles, they undergo hypertrophy. The ventricles, they become hypertrophic in nature. Okay, so that's why we'll never try to put the patient on digoxin as a first line. And also when we put the patient on digoxin, so we always try to make sure that we need to reduce the dose to as small as possible. Okay, and we should not put the patient on digoxin for a long term. Okay, so these are the few important take-home points related to the congestive heart failure.